Welcome to JBJS OrthoCorps. Listen as members of the ortho community, residents, surgeons, educators, staff, and patients share their stories about the experiences and people most important in their lives and the lessons they learned along the way. OrthoCorps is an audio archive inspired by StoryCorps and independently organized by the Journal of Bone and Joint Surgery.
It's my pleasure to introduce Dr. Rick Matsen, who is the Chairman Emeritus of the University of Washington Department of Orthopaedic Surgery and Sports Medicine, and my former chair and my former boss when I was at Harborview Medical Center. And I've asked Dr. Matsen to recount his memories of his chief, Dr. D.K. Clawson, who I had the pleasure of meeting much later in my career. But I didn't know him when I was a resident training there, but I heard some stories, and I'm hoping, Rick, that you can share with our listening audience a little bit about what Dr. Clawson was like, his leadership style, how he influenced your career, etc. So please let us know what your recollections are.
Great pleasure. So just a quick introduction about how I got here. I was convinced in my medical school days that I wanted to be a neurosurgeon. I had my neurosurgery residency all set up at, guess what, the University of Minnesota with a guy by the name of Lyle French, who was an outstanding young man. I don't know if you ever met him.
Yes, I did. Yeah.
Sensational. And then I went to the NIH and did neurosurgery for 2 years, and we dealt with intractable pain, intractable epilepsy, intractable movement disorders, and untreatable brain tumors and spinal cord arteriovenous malformations for which there was no cure. So I got somehow disaffected with neurosurgery. That was in the days before they became spine surgeons. And I said, Ann, I don't think I can follow through with this. And she said, well, what are we going to do? And I said, well, I'll see if I can apply to orthopedic programs. This was in March. So the first thing I had to do is I had to fly out to Minnesota, your backyard, and explain to Dr. French what I was going to do, because that really inconvenienced him.
Yeah.
He said, don't worry about it. You do what you think is right. I mean, the most gentlemanly thing he could have ever said. So anyway, we applied to a number of programs, all of which had great outdoor potential, Colorado and Vermont and so on. And one of those programs, the University of Washington. And Dr. Clawson said, we don't have a spot, but guess what? We'll put you in the lab for a year. Well, as fate would have it, one of the residents who was supposed to start got drafted at the last minute. So I got a call from Dr. Clawson and said, guess what? We've got a residency spot for you. So with that kind of serendipity, I wound up here at the University of Washington. And as I tell everybody, I still haven't completed my residency. But he was a wonderful, wonderful man, and very exciting to work around, because he was always innovating, always thinking, whether it was about research or education. He was a real impact player. And there's so much I could tell you about him, but I think one of the most important things as far as overall orthopedics is concerned is he was one of the early people to push for independence from the Department of Surgery. So we had a very powerful chairman of general surgery or surgery called Henry Harkins, and he controlled all the surgical specialties. And in 1964, Dr. Clawson was able to make the case to the dean, Odegaard, at that time, and say, I think that orthopedics is different enough from what the rest of surgery does that we should have independent status. And a year later, he was able to accomplish that. And I think that I'm not clear about the history of other universities. You probably know better, but I think that happening in 1965 was one of the earlier establishments of independent departments of orthopedics, which was really important. And he did on that platform, he did a lot of exciting things. in the early days, the residency program, such as it was community-based with not any particular curriculum. It was just, come and watch what I do, and then after a while you can go off and do it on your own. And no rigor at all to what it meant to be an orthopedic surgeon. And so he put together a program that was heavily based at Harborview, as you know, but also at the VA and Children's, and then a little bit at the University of Washington. And he started to put some rigor into it. He said the residents have to complete a research project, they have to study anatomy, and they have to know their stuff, otherwise they're not going to complete the program. And it got to be quite rigorous. One of the things that you may remember is he established the party line. Were you familiar with the party line?
No, I can't say as I was.
It was subsequently published as a manual of acute orthopedics.
Oh, of course.
And the thing was that when you saw somebody in the ER, you could either do it according to the party line, or you could do it your own way. But if you didn't do it the party line way and got in trouble, you were going to fall victim to what we all knew as a shaker. And a shaker is when he was very tall, and when he was angry, he was really angry. And his shakers were characterized by sort of a gradual buildup of erythema in his head and progressive shaking that we would usually rate on the Richter scale as to how big the shaking was. And he didn't care. He didn't care where he was or anything else. Was going to dress you down in front of everybody. So pretty soon people got the message that the party line was the way to go, unless you're really sure that you could pull something off in a different direction. He established and supported a big research program, several Kappa Delta awards having to do with things that are still being investigated, like cartilage regeneration and disc regeneration. You know that he was very interested in prosthetics and helped something called Prosthetic Research Study get going with Dr. Burgess, who established a program that established artificial limbs that were used all over the world, completely supported by the VA. And that was a remarkable program. He had the idea of a resident boot camp, and he found a young faculty member by the name of Sigvard T. Hansen, who would run that in its early days. And the rationale was, and this makes total sense when you think about it, is we've got medical students coming from hither, thither, and yon. We don't know anything about what their experiences are. We don't even know if they can put a cast on. So we're going to take these kids away for a week, and we're going to teach them the basics. We're going to teach them how to put on a cast. We're going to teach them how to put in a traction pin. We're going to teach them how to aspirate a joint and the basics, so that when they're on call, which could happen the week after they got here, at least they'll have some basis in knowledge. And you know Ted Hansen as well as anybody, and you can imagine he was absolutely spectacular at that, and progressively recruited other faculty to get out. And for a while it was at Lake Wilderness, and that we sometimes call Lake Bewilderment. And but we had a great time out there. And he also was very interested in incorporating other aspects of orthopedics into the department. And one of the things was the sports medicine program. So sports medicine, the care of the Huskies, which stadium is right over there, was in the hands of some well-meaning community surgeons, but they didn't really have a system of care, and it was sort of not terrifically well organized. And there were some really unfortunate results of people with major injuries that didn't quite get well treated. So he was able to make the case that the University of Washington School of Medicine should take care of the University of Washington athletes. And he became the personal emissary of this.
Hmm.
And one day he shows up with a purple and gold cat coat and a crew cut as a way of sort of getting himself in the locker room, if you will. And then he recruited this guy from the Mayo Clinic that you remember, Jim Garrick.
Yeah.
And Jim Garrick became the head of sports medicine. It's completely supported by Dr. Clawson. And Garrick did research, for example, research that was based in the safety of the athlete, not on optimizing athletic performance. And so he found that that the cleat length of football players was directly related to their risk of getting a ACL tear. And so he advocated soccer length cleats rather than these long things that people played football with. I think you were either a tight end or you were a defender. I can't remember which. Safety, yeah. So, but I'm sure remember the debate about cleat length. Anyway, Jim was not very popular because the coaches all felt that longer spikes meant better performance. But Jim was arguing that our goal here is to take care of the health of the student athletes. One of the other things I want to be sure and mention is his wife, Jan. And so he also felt that all of us should be aware of the history of orthopedics. So we had a history of orthopedics journal club over at his house. And one dare not fail to attend this journal club, otherwise one would be subject to a shaker. And so you really had to have a super excuse, like you were dealing with some life and death matter at Harborview. Otherwise, you better be there. And as an inducement, though, he had his wife was a terrific dessert cook, and they had a dumb waiter. By that I mean, I don't know if folks are familiar with that anymore, but this was an elevator that went down to the floor below, and they had a downstairs kitchen. And when the journal club was over, the door to this dumb waiter would open, and there would be a fabulous dessert that he would pass around as a thank you or inducement for the people that came. And that was really interesting to me because as you yourself have pointed out, we need to be aware of the history of our specialty. And one of the things that we are subject to right now is lots and lots of innovations without sort of our looking back and seeing how many of the innovations in the past are still useful to us today and how many of the things have just been discarded. So I'm very grateful to him for his perspective of that. He did a lot of things, about his sliding hip screw. At the time that he was doing trauma, there was a fixed nail plate. You're going to tell me if I got the name right, but just a fixed angle plate where you just pound it in the femoral neck and screw it to the side of the femur. But he noted that often that fracture collapses and then the bone loses contact and doesn't heal. So he had this idea that the hip screw would slide and maintain contact during the process. I even have not that you need to be reminded of it, but I've got a picture of it here, right there.
Oh yeah.
So that was one of his contributions. But his other major contribution to trauma was his advocacy for one Sigvard T. Hansen to go learn a little bit from Gerhard Kunschner about intramedullary nailing. And so again, you know this story better than I, but he went over to Germany to learn how to do this technique and brought it back. And the trauma surgeons they here at the time were extremely conservative, TKF Taylor and all these sorts of things, and Don Gunn, was chief of Harvard U, and they were not particularly welcoming of this new technology because everybody knew that the right treatment for femoral shaft fractures was traction or casts or whatever. So they apparently told Dr. Hansen, if you ever do an intramedullary nail on somebody, don't tell me about it. I don't even want to know that it happened in my hospital. But the rest of that is a marvelous history and another tale to be told about Sigvard T. Hansen. But Clawson was a person who really did like to support other people. F. Richard Convery was a joint surgeon who demonstrated that you didn't have to put people having hip arthroplasty on anticoagulants. You just need to get them up early and get them moving, which is a theme that Sigvard T. Hansen, of course, adopted as well. He said you don't want people that are stuck in bed. People need to get up and out of bed and move around to avoid the complications of immobility. So that he was very, very supportive. And of course, he was instrumental in my getting into shoulder surgery because he said, you know, we don't have anybody here who is interested in the shoulder. And I think you ought to go to see Dr. Neer and see if he can teach you some things about the shoulder. So I'm hugely grateful to Dr. Clawson, and to say I was crushed when he left.
Yeah.
He went to become the dean at the University of Kentucky, and I felt like, I came because of this guy. He was so kind to me and so supportive of the whole program. I said, you know, I'm here at the feet of a great man, and when he left, it was a sad day for me.
Yeah. And of course, Dr. Clawson went on to serve at the University of Kentucky as a dean and then I think chancellor for quite a number of years. And I was asked to go down and do a site visit on the Department of Orthopedic Surgery, I don't know, 12, 14 years ago. And it was a great time to spend some time because I never really knew him so much. I just heard about the Shakers. That was the extent of my knowledge. But well, Rick, I greatly appreciate you sharing your memories of Dr. Clawson, who had a tremendous influence on the development of orthopedic surgery in the Pacific Northwest and beyond in academia in general. And I'm hopeful that the future generations will have this information accessible so that they can learn a little bit about this very innovative and great man. So appreciate you doing this, Rick.
Thank you for the creative invitation, and I'm looking forward to hearing more of these presentations from my colleagues.